Hello, everyone. A very good evening to all of you. So, thank you so much for waiting. And now we're going to start the session. Today, we have with us Dr. Prabhavati Durai, ma'am, and she is going to share with us a lot of information about pain management, assessment, and all those things. Because being a physical therapist, why we should be, so much curious about pain. Actually, pain is the main thing we are going to deal with throughout our life, be it a limitation or in terms of range of motion, be it a limitation in terms of anything else. Ultimately, you're gonna deal with one type of pain or the other. Might be the patient might say that he or she might be having referred pain, some pain in the stomach, back, neck, leg, anything. So it might be acute pain, chronic pain, referred pain, neuropathic pain, and so on. The list goes up to an extent you can't even imagine. So today, to discuss all these things, we have with us Dr. Prabhavati Durai, ma'am. She is the founder and director of Power Physio Care and Wellness Clinic in Chennai. She's a neurological physiotherapy expert, and along with that, she has written a number of articles and she is a researcher as well. So, with that said, I would like to invite ma'am on the stage and we can start the thing. I welcome you, ma'am. Now we are live and we can start the session now. Thank you so much for coming, and now I'm gonna hand over the complete screen to you, and now you can start. Thanks a lot.
Thank you for the nice words, Dr. Nitin. Thank you. I'm pleasure to be here. I'm happy to be here. Okay, see, today I'm going to speak about pain, but not gently how a physiotherapist view, right? But I'm going to give you a different perspective which was missed for so many years. And I'll just before that I'll give you what is pain and a little about pain anatomy and how it is different, how hereafter we have to think for the pain, how you have to think for pain assessment. That is what I'm going to address today. Okay, so wait for the golden nuggets I'm going to provide. Right? We can put the full screen now, Nathan.
Yeah, we can put the full screen, ma'am, and so once your screen shows up, and then we can start. Did the screen start in your case, ma'am?
No, I couldn't able to see that.
So just on the underside of the PowerPoint, you have the PowerPoint thing underside. Just click on that.
Yes.
Yes, this one. Click on this, and now you can go full screen from the. Yes, again clicking on that, and yes, full screen.
Yes.
Perfect. So here we go.
Yeah. Okay. So the today's topic is physiotherapy aspects of pain assessment and management. Oh, okay. See, everybody knows like pain is an unpleasant sensation which is caused by an injury or a damage to the tissue. And everybody sees it as an unpleasant sensation, but I'll say, my patients, please respect the pain because it is giving you an alarm there is a problem in your tissue. So you have to respect your pain. While doing exercises, wherever it is, once there is a pain, it is showing you, please give an attention to it. Okay, so I said no, I'm going to give you a different perspective. The first golden nugget is this. See, we'll usually have an assumptions or trained or conditioned for pain is an objective thing because we think pain is usually addressed only by a damage in the physiological tissue. But I'm going to give you a different thing which we have to think all the four subjective dimensions. So when you hereafter think pain what it is, you have to think it is two perspective or an experience. It is one is objective and another one is subjective. Means objective is where we can localize, we can say what is the intensity, everything you will feel it. But when it is subjective, it is wholeheartedly by the patient. So in that itself, I'm going to say there are four components of it. One is perceptual component, another one is affective component, another one is cognitive component and behavioral component. Okay, so the perceptual component means this is what we are going to say, where the patient will have think like, okay, I'm having a pain in the neck, I'm having this much of pain, I'm having a pulling pain or a dragging pain, pinpricking. Like they can address all this because they have a perception of that pain. And this pain was in the morning session or in the evening session, or it is only while I'm weight bearing, like that it is. So that is a perception what the patient is having about the pain in his mind. Second is affective component, means the patient, what he experiences previously is that he's having in his mind. Okay, that is an effective component, and it mostly varies on the personality. Some people will take pain very casually, even if it is too much also they'll bear it to so much extent. But some of people where even if for small injury they'll have more fear on it, they'll think too much about it and they'll think they are weak, all that. So it depends upon their personality and what are the emotions connected to that pain. Then next is cognitive component. Cognitive component is where the patient, what he has a belief about that pain, and it has correlation with his cultural background. And if he got an information from others, this pain will be like this and this will hurt this much. All these are his cognitive component. And fourth is behavioral component. Like this is where the patient says his patterns of pain, where he'll come and express like it is this is not allowing me to sleep, this pattern where he'll come and crying and worrying, and like that he'll express it. So remember this four subjective dimensions of pain. So whenever you check any pain for physiotherapy, have this, how they are perceiving, how they are expressing it, do they connect any emotional component of it, what is their belief on the pain. All these are four most important thing here after you have to think. Okay, next it is an anatomy. I want to make it so easy so that you will understand comfortably. So pain is perceived in a peripheral nerve endings, which is called as nociceptors. Nociceptors is present in the interstitial tissues of which can get excited when there is a damage by mechanical, thermal or a chemical stimulations. Means uh, when the pain comes, pain is happening when there is an injury either by a mechanical or a thermal or a chemical stimulants which is creating it and which is perceived by the peripheral nerve endings. Okay, and you know very well that pain inputs are traveled by A delta fibers and C fibers. Okay, this first order neuron get into a dorsal horn of spinal cord, then it enters into a second order neuron where we call it as lamina 1, 2 and 5, where substantia gelatinosa is there. See, you have to remember only few words like A delta fibers and C fibers which carries the pain, and it has a junction point called substantia gelatinosa, where you are going to have a gating mechanism. Like Wall and Malzak had explained what is pain gate theory. I'm going to say that later, but you have to remember all these words. Okay, so next is, okay, I said it is all being carried. In which tract it is being carried and what are those tracts, you have to get familiar. So those are the two tracts which I want you to just remember. One is lateral spinothalamic tract, which carries about the location and character of the stimulation. Means they'll say where it is carried and what is the type of pain it is. Where the anterospinothalamic tract is responses for the effective responses of pain. Here it is effective, means the patient have emotion attached to it, how they perceive it. All these are related with the anterior spinothalamic tract. And this is again, this tract goes, ends in the thalamus. From thalamus, it is sent to so many areas, post central gyrus, hippocampus, like so many places it is being centered, where it is all perceived, organized, all that. Okay. See, next I said pain gate theory, where I asked you to remember the substantia gelatinosa, right? There, this impulses once reaches there, we have a mechanism called opening and closing of a gate, where when then like pain travels through an A delta fibers and C fibers, and which travels up to substantia gelatinosa. There, once it reaches, it stimulates the T cells and it opens the gate where this T cells gives the information above. So the pain is perceived in the brain. So you have to remember A delta fiber and C fibers, which is carrying the pain, reaches the substantia gelatinosa. Once it reaches there and stimulates, there something called T cells which is get activated. This T cells only make the gate open. So the information is passed above, and you can see pain perception is taking place. Okay, if that is the track, how the pain can get reduced? There is something called A beta fiber. This one which can get stimulated through pressure receptors or a mechanical receptors, means we have an IFT, no, interferential therapy will cause a vibrational field. Vibrational field is received as mechanoreceptors. So once you give that field, this mechanoreceptors will get activated, and it goes through substantia gelatinosa and closes the gate. Once the pain get closed, the information is not transmitted to the central nervous system. So here, once blocked, the nociception is not transferred. So the patient will feel a reduced pain for short period. Once it is reduced, you are breaking the pain and spasm cycle. Once an IFT is given, blood circulation improves. So many processes are there which helps to get rid of the pain. Okay, you have to remember in the pain gate theory, one is A delta and C fibers which carries it to the substantia gelatinosa, where we stimulate and mechanoreceptors which is helping you to get A beta fibers stimulated, so it closes the gate. Okay, these two things only you have to remember. Okay, now this is another golden nugget which I wanted to share. Please listen here, which is not even remembered by us. Okay, see, there is something called two things which you have to remember. One is we call it as descending pain modulation system, where I'm going to speak about two things. One is neurotransmitters and neuromodulators. Okay, so first I'm going to address about neurotransmitters, which include serotonin, dopamine, norepinephrine, and substance P. Like we know, substance P is related to the chronic pain. Once there is a chronic pain, the patients will have more amount of P substance. Okay, so when there is high concentration of serotonin and L-dopa, you can find the patient's pain is less. Where norepinephrine is stimulated, there you'll have more pain. I already said substance P is thought to be a neurotransmitter for chronic pain. So you have to remember, okay, if you want to reduce the pain, what you have to do, you have to increase the serotonin and dopamine. That's it. Once you stimulate it, once it is done, this neurotransmitters get stimulated, then the pain will reduce. So this is one. You have to remember this thing, neurotransmitters. Next one is neuromodulators. Neuromodulators are the chemical which we call it as enkephalin or endorphin. These are most important, we believe, to be modulating the pain, means which inhibits the release of substance P. We call it as an opioids level, and this endogenous opiates, this enkephalin or endorphins, are commonly addressed as endogenous opiates level. This have a more play in your emotional stress also. Like, see, if at all you have more stress, then this endogenous opiates may increase the pain. So stress is correlated with pain. See, these are the factors which you have to think hereafter. Okay, and most important thing, please listen here. One more golden nugget is serotonin, which is not classified as endogenous opiates, but it has profound effect on analgesics and enhances analgesic drug potency. Means the serotonin, when it is under high concentration, when there is more amount of serotonin neurotransmitters in your body, then the pain is not at all coming, because it inhibits the pain transmission. The nociceptive information is not passed to the central nervous system. Whereas if the serotonin is less in somebody, they have sleep disturbances, they have depression, and there are chances for more pain. So if somebody comes and tell you there is sleep disturbances, think of serotonin, whether this opioids are functioning or not. So this is another thing which you have to remember. If somebody says sleep problem, think about serotonin, whether it is functioning or not. So you make them to be relaxed and say them, see, be relaxed and enjoy the physiotherapy treatment. This will start working on it. The neurotransmitters, once you say, please be relaxed and enjoy the treatment, that's it. This opiates will start functioning of it, then the pain can get reduced. Okay. Now I'm going to speak about the types of pain. I'm not going to address more about the acute pain because everybody knows in physiotherapy how an acute pain occurs, because it's a damage, and naturally patients will come here and have any more treatment based on the level of injury and all that, and those things. Okay, but I want to address about chronic pain, because see, most of the people to the physiotherapy comes with a chronic pain. Please get notice of it, because see, chronic pain, I want to take an examples of trapezius fibromyalgia. The patients will at least say the history of 3 to 5 years they have a pain, and on and off it goes and comes, and when you dig the history of them, you can find the patient will have some amount of stress in his occupation, and he cannot perform well, he will have sleep disturbances, so many things. There will be a component which we have to address. So when you say a chronic pain, once you, of course, we'll give with physiotherapy, we'll start with physiotherapy, either an IFT or a TENS or an ultrasound, whatever you feel there is some spasm is there is some pain localized, you address all those things with your expertise, but start counseling these patients about what are the other factors. I said, no, what is the perception about the pain, how they behave, what is their belief of the pain they carry. All this have to be addressed for the chronic pain. So please make a note of it. Next is referred pain. When there is a chest pain, it is not actually in the chest, it is referred either in the jaw or on the left shoulder. So this is referred pain. And radiating pain, it is an neuropathic pain when there is a disc involvement, or when is sciatica, all that will have radiating pain, and a numbness will be there. Typical clinical pictures which suggests of there is a nerve injury. Okay, then central pain, it's another different pain where I want to spend little time on this, where the patient will have a central pain is when there is an insult to a central nervous system, either by vascular or a trauma or malignancy. Initially the patient will not have pain, but after some time they will start having pain. They will have a burning sensation, maybe for the whole body. They will have an irritation, even at rest. Like, it will not subside, even with surgery, anything, it will not subside. So we have to give behavioral modification and little cognitive information to them. Start living with that. Well, like, let them not think too much about it. Like, we have to concentrate about central pain. If you find they have a problem in which an allodynia is there, where the pain is not stimulated by a painful toxic stimuli. Usually it is addressed by an injury, but allodynia is where even a small fan speed can increase their pain. So it is non-painful stimuli. Okay, so you have to have an attention here. Then another one is CRPS, which is complex regional pain syndrome. Again, it is related to the sympathetic and parasympathetic imbalance which related it. There are 1 and 2 CRPS is there. Casalgia CRPS 1 and 2 are there. Again, they will have common example you could have seen in a fracture for the wrist, or somebody who have hemiplegic on shoulders. They will have a CRPS where only a wrist fracture will be there, but they will have a swelling in the hand and the shoulder hand syndrome, which you would have seen, right? They will have a typical presentation. Those are complex regional pain syndrome, which you will address through which you can address through your TENS or an IFT, which can help you get relief of it. So first, classify where they belong to, which pain. Are we only addressing with only a pain, or are we taking care of all the 3-4 components of it? Okay, next, examination. See, here I want to speak about there are something called origin, where it is starting from, where is the position, what is the pattern, and how they are saying it is a quality, and how much it is there, whether it is radiating, what are the signs and the symptoms. These all you would have seen, like variety of details, but I want to take care what is all the causing factor. Nowadays the people are working from home, so are they sitting in a proper position? Ergonomical assessment is most important here, because now the current position is like that and they're at home, so they may have so much emotional attachment to it. They may have a feel, like they may have some mental issues attached with their pain. So give lot of priority to that. We know how to detail go for an examination. You will write, the patient says pain in the morning, the patient says at rest it is reducing. That is not alone sufficient. We have to keep addressing on, like what is the causing, like whether he's sitting at proper position, how long he's sitting, how he's supporting his body. So ergonomical assessment plays a most important role nowadays, so give an attention to that. Is a monitor at a proper eye level and hand level? Is it supported well? Is the room ventilated? Is it airy? Is a light enough? It is a calm atmosphere? All that have to be assessed, because that have more role in a physical structures and also in your mental. So like I said, evaluation, like you have to observe, because I said they have some patterns of presentations, and their personality presentations will be there. So an observation is most important. Please give an attention how they are coming inside while they are walking, how they are walking, how they are presenting it. You can observe. If it is a spasm, there will be little tightness. You can little visibly see there is some swelling. All that you can observe. Observation is most important for physiotherapists. Please concentrate on that. Next is in palpation. You are well expertise in those things, where to palpate at the bony end and all that is important. Keep concentrating. And I always link pain and the spasm goes in a vicious cycle, where you have to break that cycle. That's the most important component, where the patient will come out of the pain easily. And as because when there is a pain, naturally your muscle strength will be reduced, and when there is a tightness, there is chances for range of motion is reduced. Because of that, naturally what happens is your ADL will get affected. You have to even see, if you want the patient to get recovered, attend the ADL activities of daily living which is affected, train them for that. Then only you're full holistically you are approaching it, and making them as a maximum function. Okay, this I want to say, like these are the pain assessments there. You can give, which is easiest. I commonly follow is where I'll give, for the people who can understand percentage, I give only say how much percentage on the first day. So let them understand, give an education about their pain, educate them. See, physiotherapists are here to educate what is pain and how the pain can be addressed, and give them a hope all can be cleared here itself. So first time when they come to the clinic, say your pain, you have to remember this day how much you want to say. If they are not educated, say in a money, say like one rupee to 10 rupee. 10 rupee is the worst pain, and 1 rupee, 0 rupee or 1 rupee is the least pain. See, only you have to get a measurement through them, then only they'll have a satisfaction saying how much it is. It is not through you. They have to measure their pain, how much it is, because that gives an idea for them, and it gives a clarity for a physiotherapist how we are progressing. These are the scale. Visual analog scale is a commonly being used, but McGill pain questionnaire have so much things which addresses effective behavioral, all that being there. They explain in a very detail, but it have little problem in day-to-day practice in the clinic. That's the differences. You can use simple descriptive pain scale, pain estimate, phases. At least they can draw a diagram. These are the pain assessment scales, but let the patient do it. You don't, you take the word from the patient itself. Okay, then it is in thermo, like how you will address the pain. We have a wax bath, we have an IFT, we have a TENS, we have a laser, and we have massage, and cryotherapy, so many things. And I don't want to sit and explain how it all works. We know IFT and TENS works. IFT works with pain gate theory, TENS through nerve stimulation, and it is working. Ultrasound, it is a sound wave therapy which penetrates to the cell level and alters there. Similarly, ice therapy, which helps, like ice is applied for an acute sprains and strains, immediately to resolve, and vasodilatation and vasoconstrictions all taking place. And massage, see here I want to give a importance. Some people can get relaxed with massage, but make sure like all of them are okay with massage. Some people, when there is a pain, with a different kind of pain, I said no, like when the pain is not of only physical injury, they have some presentation, ensure whether the massage is going to help them. And then there are some other pain, like even a small touch creates a pain, so make sure is it massage needed for those patients. Okay. And always when you address this physical pains, you have to decide, okay, how many days I'm going to give a therapy based on their presentation, right? Like if the pain is worst and the spasm is more, then you will decide whether to increase the number of days. But plan even the exercises somewhere here. When you have a measurement, like when the patient says the pain is reduced some to 30-40%, then you start up with exercises. So exercises also reduces pain, that you have to keep it in mind. Exercises also reduce pain, but not in the initial stage. Once the patient feels that physiotherapy is working for them, then you start with exercises. Let you give a clarity on how we are working on it. Then you can teach little stretches, self stretching. Then you can give a free range of motion exercises. Then little you can teach active exercises. Then with resisted exercises, and then make them a routine and give them a graphical presentations, or let them go to a lifestyle modifications of doing exercises daily. You have to emphasize on exercises, like they have to go for at least in walking and little warm up exercises before that. Daily they have to bend the spine once, at least they have to bend their knee at least some amount. Tell them exercises is most important, their health is the biggest asset, and for that they have to invest quite a lot of time for them. Then only they will not visit a physiotherapy unnecessarily, or else simply sitting at home can create all these issues. So let them have this. And next is, I want to speak about relaxation therapy, where we can teach to all the patients how to get relaxed. Even like if the patient comes with little stress about that pain, it can be a physical pain, there can be little stress in their mind, teach them deep relaxation exercises. Even diaphragmatic breathing exercises is fine. You teach them, like, see, whenever you are feeling stressed at your office, when you want to make a decision, make them sit in this position. Before that, ask them to take a deep breath, concentrate on the breathing, and let them do it for at least 3-4 times. Let them feel the stress is less. Already I said stress has correlation with the pain factor, so let them handle the stress. Let you educate the patient about the stress. Okay. Then there are something called, if somebody says they have a problem in sleeping, you can teach about the jacobs and relaxation exercise, where you have to make them comfortable, sit lying, like you have to prepare them, like you give a comfortable bed. Then you make sure it is properly ventilated, and little small light is there, and ask them to do every movement of one joint. Like you can say, from starting from the foot, let them do, ankle is moving forward and they're holding it for 1 second and making it down, again they're holding for 1 second. Why? That is because we are giving an information to their brain. Once they contract and relax, that body part is relaxed. Like that, you can start saying, now you feel the leg is being contracted, means knee joint you're moving. And or else you can say, like, muscle being contracted, say your calf muscle contraction, and you be relaxed, so that every one part of a body is being relaxed. So this gives an information slowly that the whole body part is relaxed. Once you come to the brain, means almost the body is done, no? How you'll make a brain to sleep? You can say, like, please concentrate on your breathing, relaxly, and believe that you're going to sleep. Like, so that once the body is relaxed, automatically your brain go for relaxation. Then next is, you can ask them to do meditation in the mornings. This is very, very important. If they do relaxation meditation exercises in the morning, early morning, I said the serotonin have a major role, no? That will be more there. Opiates will take up all the remaining functions. So this can help them. Then next is body scanning, where which area they want to get relaxed. concentrate on that area, let them concentrate on that, and say to the brain that now the pain is going away. Means we are giving, see, all this I'm addressing for their thinking about their pain. So you have to say like, now the pain is not there, it is going off, letting it go, something like that. Next is humor. What thing is, like, if you make them, if they come to the clinic with worrying and crying, then what you have to do, let them be relaxed, teach them deep breathing, relaxation exercise. You talk to them and get out of which is worrying them. So even humor can play a role. This all comes under cognitive strategies, which is most important, because we are trying to address not only the physical pain, the mental pain, what they are carrying it. Then next is one more therapy called placebo therapy, where we can try that. If you think the patient is only having the pain perception, but actually while an examining you didn't find it, you can just place electrodes and or an ultrasound and say like you're giving it and heal them. You try for 2-3 days without any intensity rise. You give a very minimal intensity and feel whether the patients are feeling only with the getting the treatment is helping them. Then you have to make them understand that the pain is actually not there. Educate them, see, you're just coming for physiotherapy, actual pain is not there. Educate them which is causing it, and please sit and find out, is there any emotions connected to their pain. Some people will have a guilt and related to those pain. So how much amount physiotherapy you give, the patient will say like, no, the pain is not subsided. So you have to sit and counsel for the patient and find out which is not allowing them to go for full recovery. For that you have to find which component, whether the injury previously happened, that fear is sitting in their mind. And if somebody will think if they had a fall in childhood, so they have an imagination that they are weak. Even for small injury, they will come up with the same thinking. So you have to find what is that which is not allowing them to comfortably come out of the pain. So you have to say like, like you are strong, you can say like, you are eating healthy. Whenever you are eating healthy, you can say like, I'm eating healthy, so I will become strong now. So you can even advise on diets where which can nourish nicely, by calcium rich foods and some amount of sunlight. All this can be an adjunct therapy to recover them nicely. The holistic approach can be done, so the patient can finally go with wellness, not only the pain release. You're grooming them for the wellness, like that. You have to have in mind, we are not only addressing the pain. Okay. Okay, this is behavioral manipulations. I said somebody will present a pain with so much, they needs an attention. For them, you can start up with exercises which is needed, and educate them. Exercises only can help to come out of those things. And operant conditioning is again, we are trying to condition them, like teaching them. See, once you do this, this pain will go. Okay. And slowly they will get educated about that pain and try to come out of it. Biofeedback have a fantastic role. If you can read an EMG with a graph and visual and audio, you can give a feedback to them, like, see, as because you're so much stressed, now you're feeling so much of electrical activity in the muscle, that you can show it in the graph, where the patient can perceive it. They will see, okay, now I have to relax. Once it is relaxed, the action potential which is taking place in the muscle will get relaxed. Usually frontal headaches, something like, where these types of pains can be addressed easily in EMG biofeedback, because the patient will feel that, okay, I'm stressed, because of that I'm having this. So that feedback gives the information they have to relax. Once it is done, then you can teach to the any other group of muscle also. So biofeedback have a important role in pain reduction also. Okay. And one more point which I want to say is something called mental resilience. Because see nowadays patients have so many issues where they are not normal. They're suddenly very silent, or they're not now they become suddenly actively speaking more. Some kind, there will be a change. Look for them. These are the alarming signals. They need some attention. So find whether how we can address them. We can use cognitive behavioral therapy. Means we have to find which all can help them come out of their emotional hurts. You have to find which is creating it. Like I said, they will have a fear factor inside, they will have a guilt factor inside. This all can help them to come out of it. Resilience is how much fast you are bouncing back. That is most important. Once you're hurt, don't go into a shell. You have to bounce back. Start preparing them. You start self-loving. You have to be more confident, and like that you have to instruct the patient, and you make them out of it. Here it is again three headings where mental resilience or coping up strategies are there, where we'll address cognitive, behavioral, and emotional component. Cognitive, already I've said, like you have to educate them, make them, this is the problem, teach them. Behavioral, what pattern they are presenting it, break the patterns and teach them. Third is you have to say emotions connected, where subconscious mind comes into play, where they'll start thinking about the pain and getting it. And nowadays you can see people, even for small things, they google and find out where the problem is, and they will go for lot of imaginations. Even sometimes some people create the pain with reading, googling. So you can make them educate about, don't try to do all this. We are an expertise, we can solve all this. So these all the way which you can treat the patient. It's not only in physiotherapy, we have to give lot of importance to other components, making them to come out of their pain, either physical pain or the mental pain, and then let them come out of it and go with happiness. We can target for a wellness too. Thank you.
Thank you so much, ma'am, for this enlightening session. It was really helpful and it was really informative. In fact, today many of my friends who used to ask me, many of my juniors, seniors used to ask, like, why do we study psychology? Why do we study medicine when we are not going to use it that much in physiotherapy? So this is the use. This is a thing where you're going to use psychology, cognitive aspects, your medicine, pharmacology. All these are going to be combined in one thing, because pain is something that has multiple domains, be it the physical domain, be it the psychological domain, and the environmental domain, because it's your environment that matters a lot. Am I right, ma'am? I mean, the
Yes, yes.
environment,
That's what I
so
address as ergonomical issues.
yeah, exactly. The ergonomical issues. So the biopsychosocial model of pain has been, put into this scenario to address all these components: the biological thing, the psychological thing, and the social environment. I mean, let's say I'm happy, I'm doing everything in a proper way, but I have some issue with my some structures in my body. So that is biological issue. Then we have psychological problem. I mean, I'm feeling all the time, oh, I'm very sad. I'm feeling like, what's happening? So that is psychological. And at the same time, I'm happy, I'm not having any physical issue, but people are not connecting to me, so I feel like lonely all the time. And then even if I get a mild pain, that will be perceived as very high, because there's no one to share. So that is where the things come in. When we share things, it reduces, and on the other way it increases as well. So that is the thing. And
No, no,
yes.
no. What I want to say is, see, nowadays, if you see the people who comes to the clinic, they're just not presenting the pain, physical pain. You have to sit and find, is there any emotions they are connecting it, or they need an attention seeking, or they feel some guilt, because people are not talking like. So we need attention on those component. And even I wanted some physiotherapy assessment to be done, where we can give a lot of importance to it, so that we'll address holistically. It's not just a pain, physical pain is being addressed.
Yeah, exactly. Very true, ma'am. So for this aspect, we have some questions from our participants. What the very first question is from Dr. Anjan Sen. He says that, Madam, please describe mechanical pain. So,
Yeah, pain. See, pain, when it is caused by a mechanical injury, um, uh, they will have a pain, stiffness, they will have a spasm, they will have a joint stiffness, all that. So anything which is caused by a mechanical, okay,
issue.
and usually in physical injury we call it as mechanical is a causative factor for that.
Mechanical pain, as the name implies, it's mechanical, right? So anything that is related to physiology or bodily structures is mechanical pain, right? So be it our muscles, tendons, ligaments, or any ish structure. Okay, the second question is from Mr. Sandeep Singh. He's saying where opioids are released and where they act.
See, all these are in your brain, central nervous system. See, that this is the two things which I really want to address. One is neurotransmitters and neuromodulators. Opioids are the neuromodulators, which helps as works as an opioids means what they'll make you sleep nicely, means you'll have some nice feel. See, whenever you give IFT, tell the patient please enjoy the session. Once you say that, immediately all this will get released, and half of your work is done on the first day itself. So educate them. See,
Exactly.
talk to them, and teach them. See, this is not only reducing, but you have to enjoy. Once you say enjoy, serotonin takes the job. It will do it, and you will heal them 100%. So it is all descending pain systems, which is in your central nervous system. Okay.
Yeah, very true, ma'am. And then we have the next question from Ms. Rashmi Sani. She's asking, ma'am, as TENS work on the pain gate theory, so could you please tell, is it effectively working on pain management because it doesn't work on the root cause of the pain?
No, see, let her understand root cause. So we have to find what is the root cause. Like, is it a nerve pain or is it a muscle pain? Is it strain or a sprain? Like, which is causing it? Once you analyze it, based on that only you'll go for it. If you feel it is just a sprain, you'll give an ultrasound. So root cause is something we are trying to go for a exact diagnosis. Once diagnosis is done properly, you will give a treatment. So TENS works on pain gate theory. Like mostly we'll say TENS works on neuropathic pains where that have massive results. So you can apply TENS on those areas. And nowadays, most of the OBG issues, TENS have little more responses compared to an IFT. But IFT have a role in normal back pains, neck pains, like common pains. But TENS, we'll say trigeminal neuralgia cases where it has marked results. And like neuropathic pains, it has a massive result. TENS can be applied.
Exactly. And at the same time, like let's say when we say that although exercise helps in recovery, but at the same time, TENS provides us that time so that we can actually exercise, because that pain-free time is very important, right?
Yes.
Because we can exercise in that time. So let's say TENS provided us 15 minutes of TENS, provided us relief for next 1 hour, so we can actually exercise for that 1 hour properly. And then the next question is, which is the most effective electrical modality for treating pain?
Last itself I answered. See, once you go for a root cause diagnosis, you will tap it. Find, is it neurological pain? Is it a muscle pain? Is it a joint pain? Find which you're identifying it based on that. If you want it is, ma'am, we couldn't able to localize, ma'am, but the patient's pain is deep inside, go for shortwave diathermy. If it is so much localized and it is only sprain, then you go for an ultrasound. If it is an acute, then you go for an eyes. Like, see, you have to find which area and what is the time duration to go for it. Fine.
Because all these structures, all the these machines, equipments have their indications. So once we diagnose a particular thing, we assess it properly, then we can actually see that, okay, this has this indication, we can use in this thing. So that is why we study all the electrical modalities. So now, ma'am, the next question is, Dr. Anjan Sen is asking, like, if a patient has psychological pain, 70% psychological pain, but pain is there, in that case, does the placebo treatment work?
No.
Is it helpful?
Yeah. First, you find any pain. is there any localized pain is there, and you just evaluate nicely. You go for an examination, palpation, whether the range of motion is restricted, or you have a localized spasm, or you can feel some differences compared to that group of muscles on either side. You just evaluate everything, you don't miss anything. Even you can measure your strength, whether is there differences is there when you're not able to localize the pain, but at least strength, when there is a strength difference, obviously there is some issues there. So you just evaluate as physiotherapist as can do it, but then you can sit and evaluate, talk to them, is there any other issues which can be addressed. Like, are they feeling so much sad about their pain? Are they getting fear, I got this and somebody died because of this? Like that, when it is, then you can go for all. First do our part, clear there, then you jump to psychology component, then you can address that. First clear here, then you address as a holistic, so the patient will become a full bloom, like fully you would have addressed.
So all the aspects, if addressed properly, then only we can actually treat the patient.
They'll
Yeah.
be very happy, they'll become a client of you, they'll bring so many patients to you.
Because when we bring good to them, they'll bring good to us, right? That way. And next question is from Miss Kahkasha. She's asking like if there's radiating pain from shoulder to wrist, then which modality will work the most? Okay.
uh, See, let her understand how, when the case will be there, when there is a cervical disc, the patient may have a radiating pain like this. Usually an IFT will go well, but few are responding to TENS too. You can try both, so it will work.
TENS or IFT both will work good in this case, huh?
Yeah.
Yeah. Perfect. So thank you so much, ma'am. And here we end the session. That was really good, and I believe all of you enjoyed the session. And I expect that in future as well, ma'am would be helping us with the same sort of sessions and sharing your knowledge with us. Thanks a lot for joining, ma'am.
Thank you, Nitin. Thank you, Dr. Shanavas, for the wonderful opportunity to me to share my things which I observed in my clinic and I recovered. Like whatever I applied, only I shared here. So I'm very happy sharing. Like, okay, thanks for the opportunity.
Because it's the combination of academic and the clinical. Because
Yes.
some people we have only academic, some people we have only clinical. But when we combine these two, the mixture is deadly. Because then you can share both the things simultaneously. We have the aspect of clinical as well. We have the academic aspect as well. So then we get the exact thing out of it. And there's one more question, ma'am. How do we differentially diagnose between bursitis pain and tendinitis?
See, tendinitis, which tendon being involved, there they will have a restriction. Bursitis are commonly in the joints, knee joints, or it will be in knee joints, or sometimes in the shoulder joint. But tendinitis, you can find it localized to one particular area where, and it is very rare. Few only will have those things. You can identify those things, and for tendinitis, ultrasound goes well, but bursitis, it is more in a little broader sense, so you have to give an IFT which works with that.
All right. Perfect. Okay, ma'am. Thanks a lot. Thanks for connecting.
Yeah, thank you, Dr. Nitin. Thank you, Dr. Shanavas. Thank you for this.
Goodbye. All right. Thanks a lot to all of you for connecting here. And it was very lovely that you all joined us for today's session. And I believe in future as well, if you like these sessions, we can connect back in future as well on coming days. I'll let you know what we are gonna head up next, and we can join back again. Thanks a lot. Stay tuned. Stay connected. Goodbye. Good night.